Thanks, Ruby. We're running a little bit behind time, which, as one of the cardiologists pointed out earlier to me, was just a classic surgeon move. So, but I think there's a few questions that at least come to my mind. I'm sure the rest of you too would be good to go. Or, Ruby, let me start off with you. It doesn't matter what the guidelines are and what we suggest. Any patient that has had any kind of endovascular therapy shows up to the ER, they're going to get a CAT scan, even if they show up with a cough. How do you manage things like that? I mean, most of the time they're going to get a non-contrast CT scan. A lot of times it opens up a bag of worms, which may not necessarily be clinically relevant.
It is a problem, and I think increased education of our colleagues is important because not everyone needs a CT scan. It can be, in fact, detrimental, especially in those patients who have baseline renal insufficiency and get a CTA. For no particular reason. It is unfortunately a knee-jerk reflex, but sometimes you pick up things that are chronic, and it prompts a consultation and like a type 2 endoleak that is chronic, and it's often seen on a CTA, and it may be worrisome to other colleagues, but it usually prompts a consultation, and reassurance is typically what is needed in those situations because nothing really needs to be done for those patients.
Great point. Tony actually just texted me saying he had to go do a type A, ironically. So he's not here for questions. But Michael, I wanted to ask you this. I mean, you showed a very nice journey and evolution of endovascular therapies over time, right? For EVAR and TVAR. One of the problems that comes with it, and I'm sure you all have seen this, is with not just trainees but early career faculty, the ability to be able to do an open operation on these patients, whether it's for device failure, migration, or complications that may not be endovascular salvage, or to do an open operation up front is very different. So the threshold, and again, I don't know the answer to that, but just how do you think we should tackle that?
That's a very interesting point, and there's a lot of validity to it. And if you take us back to the 1990s and 2000 timeframe, I remember there were special sessions for training and education when it came to endovascular therapy. Move us fast forward 20 years. We're now in the opposite situation where we need to step back and acknowledge our trainees are incredibly facile with endovascular therapy, but there's now a deficiency with open skills. So we're putting forth a valiant effort. Matter of fact, as recently as this week, the European Society has a hands-on workshop for teaching trainees open aortic skills, for which there's a large deficiency. When you look at the vascular trainees that are graduating, the number of open cases, aortic cases in particular, have precipitously dropped over the past 15 to 20 years. So I think we have to be far more fastidious from the standpoint of making sure they have a comprehensive, well-rounded training experience, giving them as much hands-on open surgical skills as they can develop. But I still feel the trend is going to continue. You think back to 2005, when EVAR superseded the number of open aortic cases, that downward trend is continuing. So we may end up in that situation in the United States where we do have those weekend workshops educating trainees on open aortic procedures.
Yeah, I mean, the nice part about technology is that it democratizes who can do this, right? And so I think the threshold of how many cases you need per institution or per surgeon may be different. But when it comes to open surgery, that changes altogether, right? Ruby, Mo, any comments from you guys? You've been a program director, and I'm sure you went through this.
So it's a problem, and I feel bad for the people who are going to develop an aneurysm 10 years from now, because if they need an open repair, they're in trouble. Endovascular failure is going to fail for any of those reasons that we showed, but also because of infection, and this needs open conversion. So when we looked at this through the Vascular Surgery Board, if you look at the ACGME minimum case requirement for an aneurysm repair, a graduate needs to do 30 cases. But they don't hold those people accountable. When we looked at it through the Vascular Surgery Board, some programs are graduating trainees with 0 open aortas. Very few programs, but they're out there. So what do you do in those situations? Hopefully they're joining a practice where they have a senior member, but it may end up in the future that you have to centralize care for those patients who require open conversion to centers who have a high volume, the volumes that Mike has shared, for example.
Yeah, I think that's so important. I know that's already been done, at least for dissection. I mean, there's time and again data that show that centralizing, regionalizing, and focusing on the volume outcome relationship is huge. So no, that's a great point. Mo, let me ask you, you went over a variety of visceral aneurysms, right? How often is organ resection and removal part of this?
We have the same problem in our Wednesday morning conference every week. With Dr. Macaroni yelling at us. But anyway, a lot of times actually the treatment is to do organ resection. So like sometimes, for a splenic aneurysm, you may just do simply a splenic resection, which if it comes in rupture with a facile laparoscopic surgeon, that's probably the best thing to do for the patient. But oftentimes, the times that you need to do resection is where there is an end organ involved, such as intestines or liver. Other than that, often you can get away with not taking any organ out because there is adequate collaterals.
That's helpful. Derek, walk us through your spinal cord protection or mitigation strategy. So particularly, let's talk about spinal drains, right? So you talked about a variety of endovascular techniques. When do you use them? Straightforward TEVAR, complexity, et cetera. Just kind of a 2-minute version.
Yeah,
30-second version.
So before, I would routinely use lumbar drains, but we found that they're very infrequently necessary. Times now that I would do it would be someone who's had previous aortic surgery, meaning an abdominal endovascular repair. Mike recently did a guy who had a thoracic endovascular repair that needed basically relining of the graft, and then also had an abdominal aortic aneurysm that needed to be treated. And that's definitely a patient that I would put a lumbar drain in. The other is typically patients who you're going to be treating more than 150 centimeters of thoracic aorta. Although even in many of those patients, they don't need it. But typically, one thing I do prefer to do is make sure, even if it's a routine TEVAR, make sure anesthesia plays the central line. One thing I don't like is people fumbling with the central line when a patient's having symptoms post-op. They wake up, they don't have a lumbar drain. We need to augment their blood pressure, and we're kind of struggling to
Now they have 22 gauges and.
Yeah, exactly. So, although not everybody typically puts in a central line for a routine TEVAR, I do tend to do that just as an adjunct for blood pressure management post-op if needed.
Great. Victor, just to switch back to your Ross, one of the things that has changed in the adult population is just to use a decellularized pulmonary autograft. Why do you use the PTFE? Just habit, experience?
At times, we published many years ago, over a decade, we started using the PTFE. They're non-immunogenic. They are less expensive. We can construct them in the OR to the size we want. So availability is an issue. At times you might have, there are plenty of papers out there, especially in pediatrics, of taking larger homographs and cutting them and making them smaller conduits, simply because you don't have every size of a homograph in your freezer. So I had a fellow from Japan who obviously in Japan that's a major issue, and they've been using PTFE tubes for a long time. And I was using them earlier here in my career, and we started using them almost exclusively. It's what we use, and nationwide it's becoming more popular. Obviously this has been discussed. The first publication on PTFE tubes utilized for an RV to PA conduit was like in 1986. So this is an old idea that is gaining popularity for 1,000 different reasons now that I think are pretty good reasons to do it. But I'm sitting here with you guys and I'm going like, I'm the only surgeon here who has 0 endovascular skills.
We can fix that. Great. Well, that was a fantastic discussion. Michael, any closing thoughts? All right. Wonderful. Great lunch it is, and we'll come back shortly with the rest of the program. Thank you.